we'll go ahead and get started. So our first session today is Policy and Legal Landscape of SSPs in the South. We have a couple different panelists. I'm going to ask them to introduce themselves and talk a little bit about the programs that they work for, kind of navigating some of, implementing SSPs in the South with the different laws that we do have, and kind of highlight some of the work that they've done, some of the advocacy efforts that they've done to get these programs up and running and get their laws in place so that they can operate these programs, and maybe some like creative ways that they've had to, implement programs so that they can still serve the people that they need to serve, but still kind of be within the confines of the law. I am based in Florida, and we certainly have some restrictive laws here on that as well. So I'm going to turn it over to Corey Davis with the Network for Public Health Law to kind of start and give us a more general overview of SSPs and the legal landscape of this. So Corey, if you want to take it away. Lily, you might have to stop sharing your screen if Corey has slides to share.
Great, thanks, Amanda. Yeah, I do have a couple of slides here, which hopefully y'all can see.
Yes.
Okay, great. So, Amanda just asked me to kind of quickly give an overview. So that's what I'm going to try to do here in just a few minutes. I'm Corey Davis. I run the Harm Reduction Legal Project at the Network for Public Health Law. And, I know it's kind of a varied audience here, so I apologize if most of you already know this stuff, but sometimes I think it's worth kind of stating the obvious, because sometimes we lose track of that. So I'm actually in California now. I was in North Carolina for 7 or 8 years. I was on the board and then chair of the board of the North Carolina Harm Reduction Coalition, and did some volunteering. So I have some sense of what the South is like, although I am not myself a Southerner. But the South in my mind is kind of like the rest of the US, just a little more Southern in a sense. So the laws in the South kind of have this sort of general philosophy behind them. Drugs are bad. People who use drugs are bad. In general, we want to make it harder for bad people to do bad things. That's kind of the sense behind, lawmaking in general. We want to nudge people in the direction we want them to go, and sometimes we do that with carrots, and sometimes we do that with sticks. And criminal law is, of course, a stick. But we want to make it harder for people to use drugs. So one way we can do that is making it harder for people to get the things that they use to use drugs, and syringes are a big part of those. So, if that's your governing philosophy, if that's how you're approaching the problem, then it makes sense to make syringes as difficult to get as possible, right? Both because at the margin it might reduce drug use, but also because people who use drugs are bad. And we want to make life hard for bad people because maybe that'll encourage them, to be less bad. That is kind of how criminal law works in the United States, right? So it's at least internally consistent, right? That concept, it sort of makes sense if that's the way you think about it. So is it working? Well, it's working pretty well if your goal is to punish people who use drugs. And here's the number of people in state prison, federal prison, local jails for drug-related crimes in 1980. That's the gray bar, and then over here, the green bar is 2015, and here we see overall number of people in state and federal prisons. So, it's working really well from a standpoint of punishing people who are involved in the use and sometimes sale of some drugs. And of course, if our sort of secondary goal is to continue a classist and racist legacy, which is, another sort of theme that underlies American criminal legal policy, you see it's working pretty well there as well. Here we see that, the number of people, or the percentage of people who use drugs and sell drugs, is pretty similar between Black people and white people. White people probably actually use illicit drugs at slightly higher rates than Black people, but we're much better at arresting and prosecuting and incarcerating Black people. So again, if that's our goal, if that's one of our goals, the war on drugs is working really well, and I'm not, saying this to be sort of facetious. I mean, I think that this is a really important thing to keep in mind, right? That the system is working. The system is doing what it was designed to do, right? It's putting a bunch of people in jail. It's perpetuating systemic racism and classism as well, right? So whether it's working depends on what you want to do, right? We are public health people. So we don't want that. Those aren't our goals. And the current system is inimical to our goals. It's working against what we want to do. And we know that just by looking at the data, right? Hepatitis C rates have been increasing for 10, 15 years. Treating hepatitis C is very expensive. If you don't actually care about people, you should care about the fact that your tax dollars are going to, treat a lot of entirely preventable hepatitis C infections. Nearly all hepatitis C infections today are caused by syringe sharing, and their carditis rates are going up. We have these HIV outbreaks that everybody knows about, and so on. So, these are all kind of, bad things from a standpoint of public health. Again, if part of our goal is to punish people who are doing bad things, then we maybe are indifferent to, or maybe we even, are happy about this. We like feeling better than other people. We kind of like it when bad things happen to bad people. That's human nature. But those aren't public health goals, right? So if we really want to treat injection drug use as a public health issue, if we want to, treat all people as worthy of having, healthy, happy lives, then it necessarily follows that we need to change what we're doing. So, something that you sometimes hear, and I'm sure that in the past I have been guilty of saying something like this myself, is that, injection drug use is a risk factor for bloodborne disease, or injection drug use is a risk factor for HIV. This is false. This is wrong. This is absolutely not true. Okay, injection drug use is not a risk factor for bloodborne disease spread. Sharing syringes is the risk factor for bloodborne disease, right? You can inject drugs every day your entire life, and as long as you have a steady, supply of clean syringes, your risk of bloodborne disease is no different than the version of you who's not doing those things, right? So if our goal is to reduce bloodborne disease infection and bloodborne disease spread, our goal should make sure that everybody has a new syringe every time that they inject, right? I mean, that's, again, it sounds really basic, right? But I think that it's really important to think about what we're trying to do and whether the laws and policies that are in place, that we're pushing for, that we're implementing, are all centered around furthering that goal, right? And of course, laws can, work towards that goal, and they can work against that goal. And, syringe exchange laws often pretend to do the first, but they actually do the second, right? They often, sort of are framed as, we're going to get syringes to people. But when you look at them, they have this at least strong dollop of, but not too much. We want people to get syringes, but only some people, and only in some circumstances, and only if we make sure that we can find out certain things about them, and so on. Okay, so, syringe services programs, SSPs are great, in theory, but in practice, law and policy is often, structural barrier to them being effective as they could be. And here are just, some examples in alphabetical order. No, not trying here to necessarily call anybody or any state in particular out, but Florida is a 1-for-1 in law. There is absolutely no public health reason for that. Everything we know about syringe access, about trying to reach our public health goals tells us that's a really bad idea, right? But the law is not designed with the public health goals in mind, right? The primary goal of that law is to make sure that we're not being too nice to these bad people who are doing bad things. That is like the animating idea behind that law. And you can see these other ones, right? Kentucky, you need to get approval from the city and the county, and you have immunity from paraphernalia laws, but only while you're physically at the exchange. Once you leave, you're fair game for getting picked up. And you've got South Carolina, where the law does not prohibit syringe exchange programs, but the state health department is pretending that it does. So anyway, so what should we be doing from a legal and policy standpoint? In my view, we don't need syringe exchange laws, right? Because what is a syringe exchange law? It is keeping the general prohibition on people having syringes. It's still saying syringes are bad. We want to make sure people don't have syringes because people have syringes who are injecting drugs with them. They're bad people, and we don't want that. But, we're willing to have this little carve out, so if people are willing to, get special permission from the local government and from the state government and jump through these hoops, and they're able to, come to a particular place at, Wednesdays from 3 to 5, we're going to look the other way, okay? That's kind of how syringe services laws generally work in the US South, right? And again, if your goal is to continue criminalizing and stigmatizing people who inject drugs, like those are good laws, like that's what you want. But those aren't our goals, right? Our goals are to, as much as possible, reduce risks to people who are injecting drugs. And therefore we need a new paradigm, right? You just need to get rid of that. You need to get rid of that, paradigm that says that syringes are bad. People use syringes are bad, and just say, actually syringes are neutral, right? And for people who are injecting drugs, having syringes on hand is good. So we want to create laws that do that. And how do we do that? Well, we just get rid of the paraphernalia laws, the laws that say that it's illegal to give away or have syringes. And then once you've done that, you say, okay, now we really need to get syringes to the people who need them, So we're going to fund SSPs, because as we all know, SSPs are not just about syringes, Nearly all SSPs provide a whole bunch of other really important services. SSPs are good, right? But they shouldn't be, like tied into this idea of, these are sort of islands in the sea of criminality, right? So you get rid of that, criminality of syringes, and then you fund SSPs and make sure they're out there in the world. I have this whole side about Alice in Wonderland that I won't bore you with here, but it all comes back to this idea of we need to know where we want to be, okay? And it's really important that we talk about, in my opinion, when we're talking about syringe access and we're talking about syringe services, I think that it's important to always frame it in this context of what are our goals, and be pushing towards that goal of syringe access, universal syringe access, right? Because every injection-related infection is preventable, right? Like everybody who gets hepatitis or HIV or endocarditis because they didn't have access to really inexpensive injection equipment, that is a policy failure. Like those should be never events. Like every injection related hepatitis or HIV infection is preventable, right? Like these would never be acceptable in a healthcare setting. Like they should not be acceptable out in the world. And so law and policy should all be framed towards making that happen. So I'll stop there. I'm really interested, again, I understand, this is not intended as a diss on anybody out there in the real world. I understand that the real world is complicated and difficult. So I'm looking forward to hearing how folks on the ground have navigated this and are working within the system that we have and trying to change it. So, thanks.
Awesome, thank you, Corey. We were all just talking about how we want a copy of your slides and how we can listen to you talk about drug policy and harm reduction laws all day long. Yeah, I mean, God, if we could just have decriminalized drug paraphernalia without all of these very restrictive laws that become like, suddenly you're operating outside of a program, and it's definitely not ideal. So why don't we move to Tyler, just since I'm based in Florida and so are you, and tell us a little bit about the work that you guys have done in Florida and the syringe program in Miami.
Perfect, sounds great. I'm gonna share my screen. I could have a little presentation here. Can everybody see this?
Yep, you're good.
Okay, perfect. All right, so thank you, Amanda, for inviting me to speak today about syringe services programs in Florida. My name is Tyler Bartholomew. I'm a fourth-year PhD candidate at the University of Miami Miller School of Medicine in Prevention and Implementation Science. I came to the university in 2017 and immediately started working with the Idea Exchange, which was Florida's first legal syringe exchange program. I want to say first legal program. They had been underground exchanges functioning in Florida for years prior to us coming onto the scene. So when everyone hears about Florida policy related to syringe exchange, they think about Hansel and Dr. Tukes and the work that he's done. I've been very fortunate to be his right-hand man over the last 4 years, looking at the implementation of the Idea Exchange, doing research and evaluation showing its effectiveness, and trying to target some of these policies that Corey alluded to with the one-for-one restrictive exchange policies and distribution. So I've worked with Hansel, and I was with him in 2018 when we tried to get the state expansion law passed, and I was with him in 2019 when we actually got the bill passed. So I'm going to talk about that journey and how long it actually took for us to get to this point, and give some insights as to some successes that we saw in the Capitol when we were doing the advocacy work, some challenges that we had, and ultimately, we did pass the syringe exchange law. And it was a very big grassroots effort and a lot of individuals who played into this. Next slide. So we, earlier this year, in 2020, we actually published an article in Academic Medicine that was the University of Miami Infectious Disease Elimination Act Syringe Services Program, a blueprint for student advocacy, education, and innovation. So myself and Dr. Tukes and our dean of our medical school wrote this paper. We actually talked about the 10-year journey to bring harm reduction to Florida. And it was it was an overnight thing. It was not an overnight thing. So really harm reduction started kicking off and coming into the foreground in 2012 when Hansel published a study showing that Miami compared to San Francisco, who had a SSP, had 8 times the number of improperly discarded syringes on the streets. And that got picked up by the Miami Herald, and everything kind of took off and running at that point in time. So you can see there, soon after, there was a House bill and a Senate bill that was proposed to allow these programs to operate in the state of Florida. We all know that, under the current legislation with the Controlled Substances Act and the drug paraphernalia statutes, it was not possible to legally operate these programs. And as you can see, there was 3 failed sessions over the next 3 years trying to get a program or policy implemented to allow these programs to operate. And one thing that was learned during that time is who the audience was. And in Florida, we have a very Republican and conservative legislator. And what they were really interested in was the economic impact of having these programs and how bad is the real problem. And what we ran into is this discrepancy between global evidence and local evidence. Global evidence in the research, we know that these are effective. We have all the research in the world to show that the effectiveness of syringe exchange, but everyone said, what is going on in Florida? So the idea was we had to generate localized evidence of this is the current situation in Florida and this is what's happening. So he published another study showing that IDO-associated bacterial infections, hospitalizations at Jackson Memorial Hospital, the safety net hospital in Miami-Dade County, was $11.4 million in 1 year. So that was really what picked it up in the conservative legislature. And then you can see then the governor signs the SSP pilot bill. So we actually were only able to get a pilot passed at the University of Miami for a 5-year pilot that was supposed to sunset after 5 years and can only be operated in Miami-Dade County. So again, a very large state in Florida, we were operating only in Miami-Dade. So you can see when the IDEA SSP was implemented, one of our first big successes that we used when we were going for statewide expansion in 2018 was the reduction in overdose deaths in Miami-Dade County. So we have a massive naloxone distribution program where we've done over 8,000 doses of naloxone at this point in time. And we actually saw those rates starting to go down for opioid-related overdoses in Florida, or in Miami-Dade County specifically. So what we actually did in 2018 and in 2019 was we found that it was really helpful to have a kind of a one-page document to give local evidence or local data, not necessarily evidence, to the legislature, to the representatives, and to the senators while we were in the Capitol. We did a lot of in-person Capitol visits. I think Hansel and I were there every single week in 2018 and there every single week in 2019. We were at every single committee meeting. We were at every single hearing. So we were present. We were always canvassing the Capitol. We were talking to as many people as we possibly could. I think I talked to a committee member who was chairing the next committee in the bathroom one time and talked about syringe exchange. So it was an interesting thing being thrown into this and actually learning how to navigate these complex systems. So the first thing that we presented was we did a research study showing that the number of improperly disposed syringes decreased by 49% after implementing IDEA Miami. So that was a great thing to show that we were improving community health and we were taking syringes off the streets. We also did a statewide analysis of the economic burden for bacterial infections. So Hansel did the Miami-Dade County. We actually were able to get a statewide data set of hospitals. And we showed in 2017, the cost of those hospitalizations was $380 million for Florida Medicaid system. And then we also had a whole team of medical students doing op-eds in the Miami Herald, talking about the syringe exchange program, talking about the lives that were being impacted and the individuals that we were helping. So we found that this was really important to bring localized data to the legislator, because a lot of times when we're from an academic standing, we do a lot of peer-reviewed journals and we publish our information, but it needs to get into the hands of those who are making decisions. And another thing that was a big impact was testimonials when we talked about having individuals, especially mothers who had lost their sons and their daughters to overdoses, come and talk in the Capitol. So this picture was from the night that it passed in the House. So this is Julia, this is Joy, this is Cindy, and then we have we actually had co-representatives for the bill on the House side. So we had our Democratic representative and now Senator Jones, and then we had Renee Placencia, who championed it for the Republican side in the House. And when we passed in 2019, it would pass unanimously in the Senate, and I think it nearly passed unanimously in the House side. I think we had 3 no votes. But it passed at 11 o'clock at night after a 4-hour abortion bill talk. So it was a wild ride. Amanda was there that day. It was wild, but it was a huge success to get this passed. Originally, and some of the challenges with this bill, originally when we had drafted the bill legislation, it wasn't anything like it was when it came out and was passed. We didn't have the opt-out or the opt-in for the counties. We had it in an opt-out framework, so it could blanket all counties and allow all counties to right off the bat implement syringe exchange. We also wrote into the legislation appropriations for funding mechanisms for these programs. We also tried to nix the one-for-one exchange that was part of the pilot, and tried to present evidence as to why we would do that. And the only way that we were able to move it through the committees was all of these reforms to include the one-for-one exchange, include counties to opt in, include no funding for these programs. So at the end of it, we got a very non-evidence informed policy, but at least allowed local counties then the opportunity to implement these programs. So I think to date, we have about 10 counties now that have passed local ordinances, 9 to 10 counties that pass local ordinances. And we have 2 other operating programs. We have IDEA Miami, we have IDEA Tampa, and then we have Flash Exchange in West Palm, who have been approved to operate. One highlight that is a big issue when it comes to doing this fragmented policy work, we were at the state and we were able to do a lot of targeted advocacy at the state level. Everyone was there. And once they made it an opt-in policy, that took the battle to 67 counties then. So we had to mobilize advocates, in these counties to be able to do this work for county commissioners to get this approved, for health departments to get this approved, and get those contracts rolling. And what happened, and I just want to provide an example, in Pinellas County, for instance, they recently passed theirs, and there's, in their legislation, they're only allowed to hand out syringes. They're not allowed to hand out any other injection equipment. So there's no cookers, there's no cottons, there's no waters, none of that. And they have mandatory referral to substance use treatment within 72 hours of enrolling in the program. So very much a restrictive policy in that county. But again, we're having this issue now where counties are doing their own thing and implementing their own policies that aren't evidence informed. So our goal really in these next future steps is to try to generate as much evidence as we can from the IDEA Exchange Miami. We just published a paper yesterday showing that sharing syringes and reuse of syringes decreased significantly over time, and that was directly related to syringe coverage. So we're hoping that showing that syringe coverage plays a really important part in these injection behaviors. Obviously, we all know this, but again, generating the local evidence and the local data, we're hoping that we can take this information, devise a data-driven dissemination strategy to target these local policymakers in these counties, or even go back to the state and try to perform the state policy in order to make it more evidence-informed and ultimately improve the lives of the community that we serve. So that is all I have for you guys today.
Awesome. Thank you, Tyler. Yeah, I mean, the work you guys have done in Florida has been, instrumental. I was thinking about that, hours long abortion debate before our bill was heard. We were at the Capitol for probably all day. We were like, do we order a pizza? We're so hungry. This is taking forever. And it'll take 5 seconds. We knew we had the votes. It was,
yeah. But it was, you were there, and it was amazing to have, a big thing read. It was almost like an end note, and it was a perfect end cap to the whole legislative session, was having Joy's testimonial read by Chev on the floor. So Joy wrote this beautiful testimony to her son that was read on the floor. It got a standing ovation. It was a very emotional moment. And then they did the vote, and it, almost passed unanimously. It was like a starstruck moment for me sitting in the gallery watching this happen. It was such a beautiful moment.
Yeah, absolutely. I'm happy you brought up a couple things that I was gonna bring up, is that since it is opt-in, each county is really interpreting this very differently, I think, or just coming up with very strange ways of interpreting this law, or putting additional restrictions on programs. What you mentioned for Pinellas County, which is where I live, is, I actually wasn't sure if they ended up doing that, only syringes. I had talked to them about that a while ago, and I was like, well, this doesn't make any sense if you're really trying to reduce HIV and Hep C. It doesn't just live in syringes, and having those conversations with them. And I believe one of the other restrictions they placed is that they aren't able to have a mobile unit. It has to be a fixed site. I could be wrong about that, but that's what I had heard as well. But really, it does just leave counties to kind of come up with very strange things on a whim. I've been in some of these county commission meetings before, and it'll just be something a county commissioner says, well, maybe they should only be able to access this program for 3 months, and then they have to go to substance use treatment. And then everybody else is like, yeah, that sounds like a great idea. Why don't we write that into this ordinance? And it's like, hold on. So, I mean, sometimes things happen very quickly. And so there is, you know, it's going to be very different, I think, in a lot of counties, and really does take like a lot of, you know, education on the part of advocates, partnering with, I mean, you guys have a unique program being based in a university and in a medical school. So you're able to, I think, do a lot of things that, you know, other types of programs aren't able to do. So I just appreciate the work that you guys do, and for mentioning that, and hopefully we can get more programs here like up and running, and maybe eventually change our law one day.
Yeah, that's the plan. We're really focusing on the next step in our advocacy. You know, we've taken a hiatus. We passed the expansion bill, but I think our next move is to figure out how we can utilize data and state level data, and also pairing that with testimonies in a dissemination strategy that's not just peer-reviewed literature, but also how we're targeting specific policymakers, local sheriffs. You know, it's not just county commissions who need to be convinced and understand the evidence behind these programs. So we're trying to figure out how we can build a more evidence-based dissemination strategy. How do we best talk to policymakers? How do we best invoke change? Because they need to change their behaviors in order for us to get where we want to go.
Yeah, absolutely. And the other thing I'll mention before we move on to our next panelist is, and this is kind of in our law too, about just, you know, having referrals to other, you know, things within 72 hours with some exceptions, but just this idea that like having an SSP is supposed to solve all of these other problems within a county. It's supposed to suddenly have everyone be housed, have everyone like get access to HIV and Hep C treatment, access to MAT or substance use treatment, without really like looking at what those access issues are in the county to begin with, and like simply having a program that's, you know, preventing infections and preventing overdose is not going to solve all of these other issues that you might have in a county with access to other services. So I think that's just important to remind folks of. You know, you might not solve all these other issues by having an SSP. It does, you know, still solve a lot of things and save a lot of lives, but I don't think people should look at a syringe service program as like, well, why isn't everyone suddenly like going to treatment or like getting housed? And it's because there's a lot of issues with access to those services to begin with. So yeah, you guys just do incredible work. Thank you. Mark, do you want to tell us about your work now?
Yeah, sure. Thank you, Amanda. Hey, everyone. It's good to see so many South Carolina people at the event. I remember this time last year, I was eating raw oysters in Charleston before COVID was a thing. So now we're staring at Zoom screens. So that is the life today. So first of all, I'm pretty overwhelmed at the moment just listening to the last two previous presenters, because there's so much good stuff being said, but also so many frustrations with, like, it seems like we know the answer to a lot of the problems we're talking about, and that is just not being reciprocated. So I can't help but feel a little frustrated and overwhelmed while talking about these things. But anyway, so a little bit about what we do. So I run a syringe services program in South Carolina called Challenges, Inc. Our office is in Powdersville, South Carolina, just outside of Greenville, which is where I am right now. And we also have some mobile units around the state: Greenville, Myrtle Beach, Athens, Georgia. And we have a good partnership with another syringe program in Charleston. And so we started about 4 or 5 years ago. And I guess I'll just self-disclose. I mean, this was born out of my own previous experience being an IV drug user for about 10 years. When I was 19, I found out that I had hepatitis C. It devastated my life and my family's life. I was very uneducated on the disease and what that meant for me. That was before Harvoni, so we had interferon back then, which was a very difficult treatment to go under. It was about 48 weeks. So about 7 years ago, I started working in the addiction field as a counselor, and then this amazing treatment called Harvoni was invented, and I was fortunate enough to be able to get that treatment and cure my hepatitis C, and it cost my insurance about $100,000 to pay for that treatment. So it was about that time where I started, seeing a need for these services in South Carolina. I spent about a year researching and contacting people and trying to figure out how we could start something like this here. I remember one day I had a meeting with a congressman, and I thought I had like hit the big times, I thought he was about to solve all my problems, and I left the meeting empty-handed practically with just having a good conversation. So it occurred to me, if you want to start a syringe exchange, you just have to start a syringe exchange. It's literally that easy. I got some supplies donated by some doctors and pharmacies, and paid for some things out of pocket. Did I get muted? Someone keeps muting me. All right, let's see if that works. Can you hear me?
Yeah.
Okay, sorry about that. So anyways, I don't know where I cut off, but I got some things donated, paid for some supplies, and started setting up in different street corners, different parts of town where there were high areas of drug use and foot traffic, and started doing syringe services out of the trunk of my car. I would give out free bottles of water and condoms and other safe using supplies. That was about 4 years ago. And since then, it's really taken off. So as Corey mentioned, we do this in a state that many people would tell you is a gray area legally. That actually might not be the case. It might be more clear than we realize, but unfortunately it's perceived as being more troublesome than it really is. We seem to have a lot of good local support, good community support. The police officers that patrol the little suburb that our office is in are very supportive. They've been to our office, they've toured our facility, and they've kind of on a handshake agreement agreed to leave our participants alone. And they've actually been very helpful. They've kind of coordinated overdose calls with us and other things. So that's on a very small scale, and obviously we're trying to, broaden that across the state and gain more law enforcement support. Obviously, with the amount of people on this call today, there is a tremendous amount of interest, I would say, in harm reduction in South Carolina. We just need to materialize that into developing some strong legislation that supports this work. And really, I would say the biggest reason for that is funding. We do all of this work on a very small budget. We get a couple foundational grants every year and some private donations. We're all volunteer based. I should add too, so we are housed in an office called an OBOT, right, which is an office-based opioid treatment program. And I just happen to own that program. So we're lucky in that we get free rent. I can, that's where my salary comes from. I can do both jobs at the same time. Obviously, that's a pretty unique setup. If that was not the case, Challenges Inc. would look much differently because, it'd be harder to devote my time to it. But the beauty of that is that we offer opioid treatment through mostly medication-assisted treatment using medications like buprenorphine and Vivitrol, naltrexone, and we do some outpatient detox when appropriate from benzos and opioids and alcohol even. And so we do all of that right here in the same office. And I was talking about this the other day with a physician who's interested in working with us. And I was just explaining how beautiful that relationship is, and that, you know, providing those wraparound services. And that's what kind of potential this work offers. You know, we provide HIV and hepatitis C testing as well on site. So people come in for syringes. These are people we would not be contacting otherwise, right? These are people who are marginalized and usually on the fringes of society. They're not engaged with a helping professional of any sort. They're not seeing a counselor. They're not in treatment. They probably don't have a family doctor, right? And so these are people that are untouched by the healthcare system. And now they're coming in here on a weekly basis sometimes to get safe using supplies, which we know what that does. And while they come in, we give them a rapid HIV or hepatitis C test, right? If they're positive, we refer them out for free treatment for either issue. And then at the same time, if they're interested in substance use treatment, we offer that, you know, like it's pretty, I don't know, I want to say common sense. It's kind of like, it just works, you know. We do that all without coercion. We don't force them. Usually we don't even mention anything about substance use treatment. That kind of just happens on its own. You know, I find that, I think Corey mentioned it as well, like the syringes are such a small part of this work. However, I guess they are the foundation because that's why people are engaged, but it allows us to do so much more. So they come in and we're able to build this rapport that's just built on compassion and dignity and respect. And it's pretty cool. And you're talking about a demographic of people who are not used to being treated that way. They're not used to someone not flinching when they see a really ugly abscess on their arm or some scabs on their face or whatever, you know. And again, I don't necessarily want to paint that stereotyped image of drug users, because drug users look like you and I on this call as well. They're not just the image we have in our head, but it's really something special happens there. Not to get all corny, but something very special happens when you treat someone like that and you don't flinch over those things and you just treat them like a normal person and get them whatever they came in for and keep it moving. So it's pretty cool. I'll also just speak to the COVID, you know, COVID being a reality these days and what that's done. Before COVID, we gave out about 250 doses of naloxone per month. Now we give out about 1,000 doses per month. We used to have about 200 contacts, I guess you would say, 200 points of contact per month. Now we have about 500. So we need money and we need help, but we're still rocking and rolling. So yeah, I think I'll just leave it on that so I don't start rambling and stuff. But yeah, thanks.
Yeah, thank you so much, Mark. It does bring up, I mean, funding is, you know, obviously a major issue for SSPs and a lot of programs across the country. I know in our law in Florida, we have a lot of restrictions on public funding for these types of programs. And just one of the projects that NASTAD has been working on is like actually being able to fund through like a patient navigation program, provide money to SSPs in certain areas to actually, you know, we know what harm reduction programs can do if they're properly funded, obviously, but to really show like the complexities of what, you know, like the lengths that harm reductionists go through to make sure that, you know, their participants and, you know, people they love get the services they need, are treated well. You know, we have people driving hours to deliver someone medication once a month. I mean, just all kinds of stuff. So really like trying to show if these programs were properly funded, all of the great things they can do. Obviously, we want to make sure at the very least people have access to syringes, and it'd be great if those were just decriminalized and, you know, weren't like then restricted by all of these program rules or laws. But since that's the way it is, at least being able to get properly funded, being in an OBOT is kind of a great, you know, situation there with getting people like immediate rapid access to buprenorphine treatment if they want to participate in that or want access to that. So yeah, I mean, we need money, you know?
Yeah. That being said, I mean, it's amazing what we can do with a very lean program, and you know, it's amazing what we've been able to accomplish. And you know, there's programs like ours, very grassroots all over the country. We're not reinventing the wheel here. But yeah, so just imagine what we could do with like real support. You know, I love like the health department model. I know the Buncombe County Health Department, just north of us here in Asheville, North Carolina, seem to have a great syringe services program there, housed in the health department. So there's all sorts of potential that could happen here once these conversations are had and people get on board. So.
Yeah, thank you. So I'm going to pass it off to Morgan. Thank you.
Hey, I'm Morgan Farrington. I'm in Huntsville, Alabama, the founder of Good Works North Alabama Harm Reduction. We have our work cut out for us here, to say the least. We don't have legal syringe access in state at all. Narcan or naloxone has a standing order, but civilian distribution is also illegal here. So that really limits what I'm allowed to do. You know, what I'm allowed to do. But we've got some legislation in the works that's hopefully going to loosen that up this session. So maybe March, April, we'll have some changes happening. In light of COVID, we did try to get an emergency order to legalize civilian distribution of naloxone just to lighten up the load on first responders. And I don't think that was actually ever fully addressed. I think it just ended up at the bottom of a very large stack of papers. And we never even pushed it because life got crazy. My program serves regularly 3 counties. And now when I say that, let me just clarify. My organization is me. That is it. So I've got some folks that come into town and we hang out, talk, we handle whatever they need to do. And like, that's how that works. Or I have to drive out an hour in any direction and go to Morgan County or Walker County. I don't know if any of y'all saw that super cool A&E documentary about Meth Mountain. I get to go there. It's a really fun place to be. Anyhow, those folks actually sued them this weekend. I had to start with basically just raising awareness here. I really came into policy work as an afterthought. It legitimately did not occur to me that it would be illegal to like turn people on into naloxone until well after I started this project. Somebody just kind of brought it up like, hey, I think that you might be interested in finding out whether or not you can go to jail for this. And I laughed and they were like, no, but really. So that's what I've been doing for the last year, is learning how to navigate all of this stuff. And it's gone remarkably well, but I think that's only, again, because like it's just me. So I'm the state harm reduction person as far as like the EHE implementation board. Um, they look to me for harm reduction stuff. They look to me for like helping to shape some policy changes, and that's really awesome. But y'all, the imposter syndrome is very real. Um, none of my work is funded at all. It's all donation based from other organizations. I get presents in the mail occasionally, which puts me and my program at risk. But whatever, it's worth it. I'll go down with this ship. It's cool. But honestly, I could go on and on forever. But Mark said a lot that I I guess I could skip repeating. I would like to point out that things aren't as bad here as maybe some folks think. We do have a good community as far as, the folks that I serve are really looking out for each other and starting to improve just outlook wise. Their own personal outlook on everything has gotten better since I've been dealing with most of them. And at the end of the day, like that's what's really important. Like damn the man, and I don't really care about the laws, but I keep getting shoved into that kind of place. It's working and I'm helping people, so it can stay the same, or I could maybe get to a place where I start getting paid. That'd be cool. But the policy stuff here is the kind of mess that you'd have to untangle for the next decade. So I don't know. I feel like my hands are kind of tied, but at the same time, it's very liberating. When nothing is legal, everything's kind of okay to do. It's really strange. But again, I think I'd rather just answer questions than rattle on about whatever random factoids we've got here, because it's bizarre stuff.
Yeah, thank you, Morgan. Yeah, I feel like a lot of the times the mentality, certainly of myself, which I've learned from other people, is like, well, it's fine, let's just do this. And, when it comes to like naloxone distribution, I remember asking like Eliza a long time ago, or making some comment like, well, we're technically not allowed to do like community-based distribution from groups here. And she's like, it's technically illegal. And she's like, what do you mean it's illegal? Like, it's just not explicitly met, you know what I mean? So I'm like, all right, let's just start doing it. And then we started doing that for years. And I don't think many people have had a problem with it. Now it's just a thing that happens and everyone seems to think it's fine. But I mean, it's risky. I mean, in certain times. And certainly, something that Mark said about like, oh, you want to start a syringe exchange, like then you start one. But, there is risk with some of that sometimes, and it's difficult to navigate. But thank you so much for being here.
Yeah, thank you for having me.
Yeah. So to my NASTAD colleagues, if there are questions in the chat that you guys want to read out, please feel free. To folks that are attending, if you have questions or please chat. We will read those out to you. I kind of have a few. I really was just, gonna see some of the stuff that you guys talked about and then kind of ask questions from there. So I've jotted down some things as listening to you guys present. I did kind of want to hear some of the ways in terms of like creative ways around. The example I'm thinking of is one-to-one exchange. And I know in Miami, there's been some ways to get around that in terms of like if there's a public health emergency or hurricanes or, certain things like that, that have allowed for more of a needs-based distribution than one-to-one. I was wondering if there were any, experiences like that in other programs, or Tyler, if you want to talk about that for a little bit in terms of ways that, there's been exceptions.
Yeah, of course. I just wanted to add to Morgan in talking about, like when you talk to a Republican legislature, like it is in Alabama, One thing that I noticed when we were doing our work in 2018 and 19 was the whole Ending the HIV Epidemic initiative comes out under the Trump administration and explicitly states syringe services programs as a cornerstone program in the prevent pillar. And I said that repeatedly. I said that all the time, wherever I could throw it, I said it all the time. I don't know if it made a difference, but I think, talking about that and leveraging the politics to it, it may be helpful, or, that's my only 2 cents on that. But,
I would love to respond to that, but I don't want to derail Amanda's question. But Amanda, can you help me remember to come back around to that?
Oh, you can. Do you want to address it now? Go for it.
Sure. So I feel I have a couple of hangups about using language that sort of throws people living with HIV under the bus and in an attempt to advocate for syringe access. Like, I don't think that we need to vilify a disease or people with a disease in order to stump for syringe access. I understand the need to eradicate the virus. I really do. And I understand how effective syringe access is for that. But I fumble with the language, and so I try to avoid it. That said, though, I think that as much as we need to bring light to the HIV situation in this state, which is really not good. Like, Alabama's so bad at everything, y'all, and we finally made the top of the list, and it's that one. Are you kidding me? It's infuriating. But as much as we need to do something about it, we need to do something about it without like smashing the two issues together. There's enough stigma with drug use. There's enough stigma with HIV. There's enough stigma with hepatitis here. We just don't. I don't want to confuse the issues and make some like super mega kamehameha like stigma machine like that bowls over my whole cause. It's complicated, and people here are so backwards, but I get what you're saying, and we're working on some language that just kind of gently suggests that mayhaps health all around would improve if we could just get the clean needle there.
Amanda, there were questions also in the chat box. Someone asked a question to Tyler asking, can you please go over the list of counties that approved SSPs?
Sure. So I believe Miami, Broward, West Palm, Pinellas, Hillsborough, Orange County, Leon County. Am I missing any, Amanda?
I wasn't counting as you were reading them off. Is that 10?
I believe and Manatee County.
Manatee.
Yes.
Yeah, I think that's correct. I did just kind of want to add to what Morgan had said. And I'm kind of looking in the chat. I have a few things I can read off from people. But I think that's really important. Like, a lot of my work is based in Florida in the past when it comes to this. So a lot of the stuff Tyler has mentioned. And I think it's, sometimes challenging to navigate, like, not wanting to overpromise stuff when you're trying to get an SSP approved or a law passed or something like that, in terms of like, well, look at all this stuff that it reduces and it increases, like, people are 5 times more likely to enter substance use treatment and do all these things. And, not that those aren't like unintentional benefits of these programs, but it's like also just the right thing to do to give people access to syringes who inject drugs from like a human perspective. And so it can be very, I think, difficult to, want to advocate, like want to show the good things these programs can do, but then not want to overpromise as well. Because I know in certain counties here too, it's like, they'll look back a year later and be like, well, why haven't you done all these things you said these programs claim to do? You know what I mean? Kind of from just what I mentioned earlier with like there being other issues to access to other services that existed anyway. So I just appreciated your comments on that. And it is, it's challenging. Okay, so a couple questions. One is, we are hearing about some alarming legislative pushback in West Virginia, which is threatening to close down existing SSP provision. Are there any suggestions on ways to support folks there? Are there concerns that this may happen in other states? I was going to give that question to Corey, but
So I'm sorry, Amanda, could you just like really briefly restate it?
yeah, I know. So they were asking about, you know, the stuff that's going on in West Virginia, threatening to close down existing SSP provision. Are there any suggestions on ways to support folks there? And are there concerns that this may happen in other states?
Yeah, I mean, I definitely don't speak for the West Virginia folks. I mean, the folks at SOAR are fantastic. They are super organized. They are super connected to the local community. They've been really effective at getting some op-eds. There's one last week from the local business community in support of the program. There was one that just came out yesterday or the day before from local faith leaders in support of the program. So, I mean, they're just doing a really great job of that, you know, that local ground game, right? Which I think is really important because there's, you know, it turns out that there is a small group of vocal people who are trying to make it seem like this is a big problem and everybody is opposed to the exchange. And that's not the case. It's really not the case. A lot of people support the program, and the more people that understand you know, the goals of the program and you know, that the people behind it like are, you know, not bad people. They're out there, you know, the folks in the community trying to do good things to help the community. More people come around. So I don't know. I think that I would defer to the SOAR folks. You can find them on Facebook. It's SOAR, and just, you know, kind of ask them how you can help. You know, I don't know. I mean, it's tough, right? Because West Virginia is one of those oddball states from a legal standpoint, where if you look at one of those like maps where that like there's just the states that are colored, it's one of those states that, you know, kind of, you know, gets the color that's like syringe exchange is totally cool here, because the state does not have a law that prohibits the giving away of paraphernalia or the possession of paraphernalia. But what happens here is there's, you know, the city of Charleston is doing a bunch of sort of things through municipal ordinances that are trying to shut down the program. You know, so from like a legal policy perspective, a thing you can do is make sure that you take away local control, right? Which is something that, you know, is difficult, right? I mean, a lot of syringe access laws have this local control component, right? It says, you know, well, you can have a syringe exchange, but only if you get approval from the local government, or you at least, you know, local government at least doesn't oppose it. You know, it goes back to this idea of like, why? Like, what other, you know, evidence-based positive programs do we have, you know, that like local government has like veto over, right? I mean, it's, I don't know. So like, I'd sort of say from a legal policy standpoint is, you know, make sure you have state laws that are permissive at the state level and also keep municipalities from doing shenanigans at the local level. And we see similar stuff in Michigan. Michigan is another state where, you know, it's not illegal to give away or possess syringes, but you have a bunch of local ordinances that try to make syringe exchange illegal. So you have this wacky situation where, you know, the syringe exchange is operating legally in one county, but if you're driving home, you know, to another county, you could get stopped and arrested for having those syringes under a municipal ordinance.
Yeah. Corey, can I just interrupt with here? No, I really like appreciate that, and I want to come back to that idea of like home rule and local ordinances, because that's a thing in the South that happens a lot. But I also want to recognize, specific to the West Virginia prompt, is that we do have Robin Polini here on the line, and we unmuted her, so I don't know if she has more that she would like to put in and kind of add. In terms of
I think Corey did a great job of covering that, and his support for all of us, I think, in dealing with these legislative issues is really appreciated. He's an amazing resource and has been to us as well. So to clarify, we have two issues in West Virginia. One is there's a local effort to try to shut down the only needs-based syringe program in Charleston. And while we were working that, we then went into legislative session, and now there is an effort to regulate at the state level syringe services programs. The first version of that law on the Senate side was horrendous, and it's now been modified, but it still has content that would really restrict our ability to run programs. And I could go down a long rabbit hole talking about that, but I would just say this is that this bill came up last year as well in a different version. And the consensus was that it needed to be handled internally because like many of your states, our decision makers often don't appreciate outside influence and commentary. And so it was able to be killed in legislature last year, just very quietly. That isn't the case this year. And I think we've been talking amongst ourselves about when is it appropriate for folks from outside West Virginia to come in and help us. And I think the ACLU website and Facebook is a really good place to look for action alerts where we really want people from outside to participate. But I will say this, which is, you know, infectious diseases go across borders. And so we have two very significant HIV outbreaks right now, one in Charleston, one in Huntington. Huntington is right across the river from Ohio and right across the river from Kentucky. And so people from other states have a vested interest in the policies that we put into place in West Virginia and vice versa. And so I think, you know, when the time comes to comment on this stuff, I think that's an important point to make, is that we border 6, 7, 8 other states. And so what we do here affects you as well. But we appreciate the support. It's been a little rough around here lately, and I'm sure you can all relate.
Yeah, thank you. Thanks, Laura, for jumping in, unmuting Robin. Yeah, if that'll happen in other states, I mean, I hope not. I know some of the things when we're talking about like really bad policies and stuff, it's like we don't want to mention it to put ideas in people's heads to then have them be like, oh yeah, let's do that. It's tricky.
Can I ask a question? Similar, if that's okay.
Yeah.
Because, you know, I actually will say that the proposed legislation in West Virginia, these are all kinds of threads that come together. It actually looked a lot like Florida's law, which is horrifying just on a policy level, and just very scary. You know, couldn't use funding, couldn't, you know, no public entities could be funded, that sort of thing. And so Robin mentioned, you know, making amendments that make it like a little bit better, which I agree. I'm curious if any of you can talk about some of the concessions that you've had to make or have chosen to make in your advocacy, you know, in order to get something passed, anything passed. I'm looking at Idea Exchange for sure, who I know that there's deep regret from some of your folks that, oh, stop, you don't have to do that, you know, about the 1-for-1. But you got it passed, right? And talking through some of that, thinking about Morgan, the Alabama law that at one point was statewide and then became a pilot, again, mirroring Florida. Okay, any thoughts you all have about that?
Let's just continue to hate on Florida. I mean,
Unleash the wrath. I don't, you know.
There's a lot of content to hate on about here. You know what I mean?
Unfortunately, our policy did kind of mirror Florida's a little bit. We've pushed that back another year because somebody came into the scene that wants to do a stakeholder analysis. So we're gonna let them. It's probably for the best that we have some legs to stand on when we actually get this in front of legislature. I mean, it makes sense. We might want some data. The fact that that wasn't thought of is embarrassing. But I think, you know, just as kind of a stick it to the man little thing, we wanted to write some precise wording into the bill now that is exactly West Virginia's, out of their laws, just for our own satisfaction. Because like solidarity with West Virginia for real. Sorry, y'all. That's rough stuff. But you know, if y'all end up where like in the situation that I'm in, just email me. I'll try to mail you some stuff.
Oh, we got it covered. But thank you, Morgan. Contingency planning is in the works. I will say to that question, like there has been conversations, and this is something you might face, is there were real conversations here about, do you want to kill the bill or do you want to try to make it better? And to the extent that you make it better, you might reduce your chances of killing it. And so I think you really have to listen to the programs when you're making those decisions and do what they want. But if anybody's up against this, I mean, I'm sure Court can help you, but we've had things come up that you would just never expect physicians on a health committee to say or do. And so I'm a scientist, I'm an academician, and facts are really not the driving factor at this point, I think. I might move back to California because I'm not needed here anymore.
Yeah. Knowing when to kill a bill. It's very tricky. Mark or Tyler, did you have thoughts on Laura's question about concessions made in your states?
I mean, I don't have much to say on that other than we have a South Carolina harm reduction bill that was reintroduced again this year. It's sponsored by a state senator. And I'd like to say that I'm optimistic about it, but after speaking to the sponsor, I don't know if that's how I feel anymore. So I am not a political science guru. That is not my forte. So to my understanding, we are just trying to gain bipartisan support on this. We're trying to get it to go before subcommittee so we can give testimonies. But again, I don't know if that's, is that the wise move here? I don't know. Should we start all over and have a new sponsor? I don't know those things. So, but that is happening in South Carolina, which is somewhat exciting, but yeah, we've got a long way to go.
Yeah, thank you. Tyler, did you have anything to add? We've hated on Florida a lot, but
Yeah, I think everyone's looking to me and say, you passed a terrible bill. That's all I want to hear. That's what they want to hear. But the way it was written when we first proposed it to the legislator, all of a sudden became Frankenstein when it got to the end. So it was just not how it was written, but it was the only way that it moved through anything. It got held up so many times, and we tried to hold on to those key components like the not one for one, or allowing it to be an opt-out policy for the counties. It just didn't fly at all for the state. So those were things we had to let go of, and our bill sponsor just pushed it through. And I feel like we were still lucky enough to get it passed in 2019. In 2018, we had a better looking bill, but then the Parkland shooting happened. And I was in the Capitol the day that those individuals came and spoke in the legislature, and there's 10,000, 20,000 people outside the Capitol related to that. And session kind of put to a halt on all bills, and, nothing moved forward that way. So it was just kind of political suicide at that point.
Yeah, absolutely. So I'm going to read some questions from the chat here. Do you think that regular opposition to syringe access is combining with the more recent I can't read this word, demonization of public health in more conservative areas that happened since COVID?
I think people here care less, honestly. They, at least about the people that syringe access would affect. That's fallen way to the bottom of anybody's priority list, except for all the things that they were complaining about. But as they don't care anymore about us, that's for sure. It hasn't really mixed up in conversations. It's not like oh, but what about the COVID spread that would cause, or any of that, because most of the people here don't believe in science. And so COVID doesn't exist. And the vaccines are all like vapor trails or something. I don't know what these people think around here, but it's retarded. Like I cannot with them. It's yeah, COVID's not even real. So obviously it's not affecting the attitude about syringes.
Yeah. Other thoughts from other panelists here? We have some other questions, but.
I don't know. I mean, you know, unusually for me, I mean, I'll be the optimistic one and say, you know, we have seen some places that have made it easier to access syringes because of COVID. You know, we saw Maine lift a 1-for-1 requirement and permit syringes to be mailed. You know, Pennsylvania permits naloxone to be mailed. I mean, we have seen some changes that have been made, you know, under the argument that, look, you know, people can't access, you know, it's harder for people to access these services due to COVID restrictions, so we should make it easier for people to get them through a variety of ways. Other states have done that as well. And, you know, there is a hope that, you know, it turns out that this is a good thing. It's a good thing during COVID, it'll be a good thing after COVID, so that some of those you know, reduced restrictions on access to harm reduction supplies will continue after.
Yeah, we had been certainly, you know, mailing naloxone for a number of years in Florida, and had been partnering with Next Distro as their, you know, affiliate in Florida at the time, or still are. But I will say, I mean, certainly once COVID, you know, once a bunch of providers were like not able to see people in person and closing their doors, even though we had already been offering to mail naloxone to folks, it was a lot easier to convince programs. These are not harm reduction program, you know, drug treatment providers and other programs who, you know, weren't super harm reduction based. Really, they were super on board with mailing naloxone and informing their participants about that. And some of those programs were even like, oh, we'll just start mailing it as well. So yeah, I mean, and some of the, you know, lesser restrictions on buprenorphine and kind of methadone, I think we all hope will stay post-COVID. I did have just a quick question for Mark from the chat. They were asking, you mentioned free treatment with your setup currently, and they asked what dollars are used for treatment in your area or state.
So they're probably referring to the hepatitis C and HIV treatment, I'm assuming. So we partner with our local AIDS-based organization, and they are the ones that handle that. So they provide all the HIV treatment, and then for anyone needing hepatitis C treatment, they refer to the local hospital system, and they have grant money to use for hep C treatment. So we don't handle the, you know, I'm not involved with where that money comes from specifically. We just, it's through a partnership with an AIDS-based organization.
And for like the opioid stuff for substance treatment, can you speak to that as well?
I'm sorry, you broke up a little bit. Say that. What was that?
For buprenorphine or substance use treatment that you guys also are able to either offer or partner with folks, can you speak to that as well?
Yeah. So that one is a little bit more difficult. And I'm not super knowledgeable on the history behind the grant funding, for example, like SOR funding for opioid use treatment. But in South Carolina, we, as a private practice, we do not have access to that grant money for opioid use treatment, which is really disappointing, because I think the money would probably go a lot further with a small agency like us. That being said, we don't have access to that grant money. So the only thing we can do is choose to eat that cost. And again, you know, as being in the position to make those decisions, you know, I'm lucky in that sense. And so we just eat that cost, and we call it like scholarshiping. So we will scholarship usually just a small amount of time, like the first couple weeks. We'll scholarship the first couple weeks. So it removes that financial barrier. Someone can enter treatment when they want to, not when they can afford it. And we just eat that cost. We just scholarship it. If we had to pay for something, we would do it out of donated funds. But luckily, you know, we'll just get the doctor to do it pro bono, counselor pro bono, you know. So yeah, but so we do that. We just scholarship the first couple weeks to remove that barrier. We'll help them pay for their prescription at the pharmacy. But that's not like a great long-term solution. The idea there is that it gives someone a chance to stop spending money on their habit on the street. They can, you know, be on buprenorphine, for example, be saving money. Hopefully we can help them get employed again and put some money in their pocket so that they can afford treatment. Or in some instances, we've been able to get them signed up with health insurance through Marketplace. And we are in network with some commercial insurance providers. So, you know, so we've got to work it, but that's kind of what we have for options right now.
Thank you. Morgan, yes, to what you asked me. Discussing, so we have a few minutes left, so I think this will kind of be our last discussion, and then we can just do some closing thoughts from you guys if you have any to share, but discussing funding challenges as they relate to legislation. Please feel free.
Well, so for instance, because everything is so ridiculously outlawed here, I would have to develop like kind of a shell organization or program in order to have something to hide what I'm doing behind if I were to be a 501c3 who is trying to get granting, because you cannot ask people for money and then tell them you're going to go break the law with it. They typically aren't behind that. So I can't get money. And I was just wondering if anybody else on the panel has come up with any kind of creative solutions to that problem.
I mean, go ahead, Mark.
I was just going to say, I think it just depends on the funder. You know, a lot of times they don't care. Sometimes, yeah, specifically, you know, like a large HRSA grant or SAMHSA grant or something is probably not going to fly, but a lot of small foundational funders don't seem to really care either way, in my experience.
Yeah, I was just going to add, I don't think there's a lot of grant funding specifically for the syringe exchange piece to the puzzle of what we're talking about. I mean, Corey talked about the syringe is a very small piece. And there's so many wraparound services, you know, at Idea Exchange for HIV linkage to care. We have telehealth for all these specialty pathways for Hep C treatment, for medications for opioid use disorder. All of that stuff is getting funded, which funds our staff who can then do the syringe exchange itself. So as far as purchasing syringes and all the equipment needed, it's been a lot of private donations. We have a gift account where we're able to do that with. But that's the issue, is that a lot of the foundational grants are, like you said, tailored to HIV prevention or tailored to HIV treatment or Hep C treatment or research that needs to be done or needs to be conducted. So a lot of the times that's where the funding goes to, instead of funding the core aspect of what is trying to be done.
Yeah.
Yeah.
So we are at time. I was just going to mention separating the actual like syringe part of your program from wraparound services, I think is a thing they have to do in Florida a lot as well. But we are at time. It is 1:30 over here in Florida, at least. I just wanted to thank our panelists so much for participating in this session. I wanted to give you all a quick, you know, if you have a few words that you wanted to share before we wrap up today, but so if you have any closing thoughts, please feel free to share, but thank you guys so much for attending.
Thank you. It was nice to see everybody. Nice to meet everybody.
Thanks for having me.
Yeah, thanks everyone. Thanks for being here.
Yeah, thanks for having me. Good luck.
And